I only have, I think, 6 or 7 slides, and I go through those and then we discuss, but we can do both, because I don't think, I wanted to give you some concepts in anaplastic, and part of our research we do to poor little mice is we give them anaplastic thyroid cancer, and then we try to cure it. So we use them as examples of how we can sort of, and we do differentiated thyroid cancer as well. So that's one of our models we use is mice to try to take care of thyroid cancer, so we don't have to be doing guinea pigs on people too much, but we do that with some studies. Oh, this way. The way, and I'm going to have this as the last slide as well, to let you all sort of know what we do at the University of Colorado for patients with anaplastic thyroid cancer. And this is out of a book that was recently, the book called The Thyroid, which is a major kind of thyroid book. Cooper and Braverman are the editors on it. And they asked me and my colleagues, Dr. Josh Klopper, who's in endocrinology, and Dr. Madeline Kane, who's in oncology, to write the chapter on anaplastic thyroid cancer and then some other miscellaneous tumors. And what we put together was sort of this algorithm, and this was before the, I don't know how many of you know, the American Thyroid Association has anaplastic guidelines. This was just before the guidelines came out. These were the guidelines here, led by Dr. Bob Smallridge from the Mayo Clinic in Jacksonville, with a number of experts in oncology, endocrinology, surgery, and even someone in ethics to help sort of with this, because I think there are a lot of ethical issues that come up in patients who present with anaplastic thyroid cancer. So the way we think about it in general is we want to do a rapid evaluation. I'll show you a little bit more about that on the next slide, of someone who has documented or suspected anaplastic. And those of you who know about anaplastic, one of the first concerns is, do we have the right diagnosis? Because there are some other cancers that can kind of look like it, and they're treated very differently, so we want to make sure we're sure of the diagnosis to begin with, because we can then do the right therapy. And so we basically check what's called the functional status of the patient, which how are they doing? Some people are in perfectly good health and they present with a rapidly growing mass. Other patients are very, very ill, have multiple other illnesses, and present with that same mass. And we're going to approach them potentially differently based on the outcome, potential outcome of the cancer. And then so what we say, we ask the question, what's the ability that we're going to have to help that patient's survival? Because, and I'll show you a little bit of data, but unfortunately anaplastic has a very, very poor survival. And then what's their ability to tolerate the therapy? We want to do both of those. Because sometimes you could say, well, they might be able to tolerate the therapy, but we're not going to be able to influence the outcome. And so do we really want to put them through it just simply because they can tolerate it? So we want to really weigh those and what are the factors there in their functional status. And so we divide that into what we call favorable and unfavorable. A patient who's usually younger, has a good functional status, they're overall doing well, tumor looks like it could be resectable, and that's why we want to do CAT scans and all these other things, and we don't find distant mets. Every patient, when I see them with anaplastic thyroid cancer, we do a PET CT. We want to make sure that if it's in the lungs and other places, it totally changes what you're going to do with the original disease. And we consider originally a clinical trial, if we can, if there's a good clinical trial available, and I'll again show you a slide on that. And then we consider if clinical trial wouldn't work, the best standard of care therapy, which again we believe is considering surgery, external beam radiotherapy, and then chemotherapy in some patients that's what's called taxane-based, these taxane-based chemotherapies, because I believe they've had some of the best effects that we've seen in patients with anaplastic. If in fact these factors are unfavorable, and we have some patients that we just then move into palliative care, try to make them comfortable. Don't shorten their life by giving them some toxic chemotherapy that could hurt them, and try to keep that patient comfortable with pain management. We maybe do external beam radiotherapy to protect and shrink back the tumor in the airway. There's other things that we can do. We even use some low-dose chemotherapy in patients as palliative care. So palliative care just doesn't mean go home. There are things that we definitely do, and this is where we get our palliative care team involved as well. And we want to do all this rapidly. So again, I'll show you this algorithm at the end. And the way we do this, we actually even gave it a name at the University of Colorado, the Rapid Anaplastic Response Team. And what it is it involves the medical oncologists, you see here, endocrinologists, surgeons, radiation oncologists, interventional radiology, where you can stick things in and burn it out or inject it with something, palliative care, and we do this right up front. Every patient with a diagnosis of anaplastic, I don't care if it's just a centimeter or so, we get our palliative care people involved. because they really are very good at talking to the patient, even better than we are, about what are your wishes, what are your values, what are things that are important, so we can help tailor our therapy, because these are some pretty aggressive therapies that we do. So we get palliative care involved right away, and then we have our patient care coordinator. And interestingly, we've done this for a while, but one of the recommendations in the American Thyroid Association guidelines for anaplastic is comprehensive multimodality management plan should be rapidly formulated and implemented by a multidisciplinary team. So the recommendation is to do that. And our goal is to get that done within the first 48 hours. You think about, come to the university or a major medical center, you see an endocrinologist first, maybe a week later, 2 weeks later, 3 weeks later, you see a surgeon, maybe we ought to get radiation oncology involved, that's another 3 weeks. You can't do that with anaplastic. You got to jump on it right away. And so what we do is we engage the whole team right away. Some people may say they don't need external beam, but we want to get everybody involved, and then we powwow and we decide how to manage that. So that's sort of how we do it at the University of Colorado. And again, feel free to interrupt me with questions. So how well do our therapies work? And again, in this chapter we wrote, what we did was we looked at sort of the median survival, and this is what's called historical therapy. So people got various different forms of radiation, chemotherapy, and you can see some of it's pretty old, dating back to even the late 1940s. But, fairly big numbers, because these are just historical cohorts from various big centers. And this is in the whole United States. So this was basically through the National Cancer Database. But you can see median survival from diagnosis is poor with anaplastic. This study was 3 months, 3 months, 4 months, 5 months, 3 months. 1 year survival is down around 10 to 15%. So that's kind of what we had as historical background, because it's hard to do, and I'll show you actually a well-done clinical trial that used sort of a standard of care and then added some other therapy. But most centers, even the newer data we have, aren't good controlled trials. But this is what we had to work with historically. So what the newer data shows us, and this is again this taxane-based, which is a chemotherapy from the yew tree called paclitaxel, and there's another one called docetaxel. I personally believe that if you're going to treat somebody with anaplastic, this should be part of that therapy if you're going to treat them with chemotherapy. You could add things like what's called doxorubicin or carboplatin, but this you should use to begin with. And really some studies, this study we participated in, Dr. Kanane led it, where patients got a 96-hour infusion. It was kind of a weird way to give it, but 96-hour infusion of paclitaxel, that taxane. And we had 2 patients on that trial. This was, again, a prospective trial, but only 19 patients enrolled, which for anaplastic, that's actually a big number, relatively big number in trials. But we had 2 patients who actually did very well, who had metastatic disease, and it shrunk back for a while. Unfortunately, it came back, and when we give these standard chemotherapies, one place it does come back is in the brain, because you can't get as much of the chemotherapy in the brain. Yes?
Recently, there was an article in the New York Times about a woman who received everolimus with anaplastic and went into a 4-year remission where her cancer was undetectable.
Mm-hmm.
Do you know about any other usages of the TKIs in these cases?
Yes, and
Or is that just like a one-step?
one-off deal maybe, yeah. No, there are a number of studies that started with one kind of remarkable patient. The one thing I'll say in general is, of anaplastic patients, and we truly believe they're anaplastic, because sometimes you could get a misdiagnosis, and I think some of the older literature of showing kind of some response rates that might be lymphoma instead of anaplastic, so you have to be careful. I'm sure this wasn't anaplastic. But there's about a 5% cure rate in anaplastic, 2 to 5% cure rate. So there are some people who get cured.
Cure rate meaning they're alive after 5 years or 10 years? What's the definition of the cure rate?
Well, cure rate in a lot of these is you don't find any disease whatsoever. And usually it's after 2 to 5 years. Yep. So there is, but anyway, no, these are always intriguing, these single patient studies. And then what we need to do is to do more careful trials. Because what I believe... Could be. There's a pathway called the mTOR pathway. It's PI3 kinase mTOR pathway. Yep. And then you could hit that pathway. I personally believe, and I'll show you, I don't think anybody should get just one drug with anaplastic. It's too diverse of a tumor and too aggressive. I think we need to be doing these multi-drug therapies, but these mTOR inhibitors maybe could be part of that.
Last year there
Oh, his name is Ross Kagan, probably.
Yes.
hmm
I was wondering.
Yeah, he's curing fruit flies of cancer. And fruit flies don't even have a thyroid. Yep. But anyway, you see here these taxane-based therapies. I believe that there are some. This one, a nice one from the Mayo Clinic, 60-month median survival, going from 3 to 60 months. Now, still 60 months, you'd like to live longer, but I think we're finding these combination therapies, and they're pretty aggressive therapies, but in the appropriately selected patient, we can get some good long-term benefit from really going after them with this. And so this was kind of how we put this in the table format, and where my belief is until we see something better, if somebody's going to get systemic therapy, I believe it should either be a clinical trial or something that includes a taxane, one of these taxane drugs. This study was very interesting. We were fortunate enough to participate in, and this was a company run and sponsored study, but there's a number of really interesting points out of this. This was the largest ever prospective trial done in anaplastic thyroid cancer. 80 patients were enrolled. It's very impressive. Unfortunately, what we were trying to get was 180 patients. And it also shows you that it's hard to fill big anaplastic trials. And this was over many, many sites in many centers. And what it did was it used this what's called kind of vascular disruptor, and you may have heard it called CA4P, combretistatin. The name that is used here is fosbutabulin. And that's used together with standard chemotherapy of paclitaxel, that taxane-based, and carboplatin. And so it was randomized where for every 2 patients that got this special therapy together with the chemotherapy, 1 patient got just chemotherapy alone. And to say, is adding this drug to a standard chemotherapy going to be better? And this was just recently published. And so there were 3-week cycles, and they did 6 of them. And what you'd do is you'd get either that fosbutabulin medicine on days 1, 8, and 15, and then your chemotherapy on day 2, those 2 chemotherapy drugs, or just the 2 chemotherapy drugs alone on day 2 every 3 weeks for 6 cycles. Then the people who were on the fosbutabulin, they would continue to get that as maintenance on days 1 and 8 every 3 weeks. So this was kind of this new study paradigm of using 3 drugs versus 2 to see how they did. This is the kind of bottom line answer. If you look at the lines, the people who got the 3-drug therapy look like they did better from an overall survival standpoint than the ones who got 2 drugs alone. This wasn't statistically significant. So technically there's no difference, statistical difference. Remember though, one problem is this was powered for 180 people. So we were hoping to get 180 people to do this. It looks like there could be a signal here, but it just wasn't strong enough on 80 people to tell us that there's a benefit of adding this drug. There may be some future studies. What was interesting then, there were what are called sub-studies. This was the primary one. But within it, they looked at people who were younger, so under age 60. There actually was a benefit, and it was significant, quite significant in this group. So maybe we should be giving this to patients, again, younger, more favorable functional status. And if you compared it to the over 60 group, it didn't make a difference. So maybe an older patient who isn't doing as well, you don't, because these are toxic medicines. You wouldn't consider it, but maybe we ought to redo some trials and consider younger patients in these trials. It's nice to see younger being yet less than 60 rather than less than 40. But so this is kind of the new concepts that are coming out, and I think these multi-center trials are really great. And there's a number of these that are being done. And it's hard to do an anaplastic because you have just a few people all over the place. And so I really give this company credit for trying to pull these sites together to do this. And it just came out this year in thyroid. The other thing is clinical trials. So what I tend to do with my patients is I'll go look, and this I just looked a couple of days ago, and there are 2 main trials that I see on clinical trials that are actively enrolling patients. So if you have somebody with anaplastic, this is one from the National Cancer Institute. This is actually a drug, I don't know if it's a cousin of combretistatin, but they claim that it is like it somehow.
It's very close.
Very close. These microtubule kind of inhibitor? Yeah. So they're using this drug here plus cisplatin, which I must admit if they consulted me, I would have said use a taxane, but it could be that this is the taxane-like drug they're using in these people with anaplastic cancer. And then this one uses radiation plus, again, this paclitaxel with one of these kinase inhibitors you're kind of asking about. This one called pazopanib. And so this is this is one that they're doing a multi-center trial, 96 sites. And there's some reason to believe this could be a pretty exciting and useful therapy. Radiating the main tumor after it's taken out, tumor bed, and giving these two chemotherapies, paclitaxel and this pazopanib or kinase inhibitor medicine. And part of the reason this is exciting is there was a study out of the Mayo Clinic that really they did everything from basic science all the way to treating one patient, but it was only one patient with anaplastic, with sort of this combination. They did the paclitaxel plus this pazopanib. And they showed, interestingly, in this patient was started treatment in January, early February of 2011, had all these big anaplastic tumors in their chest, and this usually means it's going to rapidly grow and they're not going to live very long. And this is one now 6 months later, where you look at this, it just really has shrunk it back. So there's reason to believe this could be a good potential therapy, and that's why they're doing this multi-center study using three things: radiation, standard chemotherapy, and this new kinase inhibitor. And that's why I feel you shouldn't just use a kinase inhibitor alone, or maybe even just one drug if you're going to try to do your best effect. Yeah?
Is entrance into all three of these trials a requirement that the patient is treatment naive, hasn't had any treatment?
I didn't, when I looked at those, I didn't look at that specifically to make sure, but it always is a good, because some are treatment naive. A lot of times they're not necessarily treatment naive patients.
I'm thinking in terms of the speed at which treatment ought to happen and the issue of enrolling in the trial and the time it takes.
Yeah, like I'd be pretty sure that the trial that involves radiation, you probably couldn't have had radiation before. You could have had surgery, but not radiation. So some of these trials, you also have to look, you're right. And with anaplastic, that's a big problem, because then just try to get somebody to fly to DC to the NCI to say, am I, But I think they're good about they'll actually pay for people to come out, and they move it pretty quickly.
So you as a doctor doing research have to have a good network of communication with your colleagues.
Yep. And every time I see, because I don't see, I maybe see 3 to 5 patients with anaplastic a year. So it's not like I'm seeing it all the time in my clinic. So every time I hear about one, we activate the rapid response team, and I look up and see what current clinical trials are enrolling. So I know that by the time I go in to see the patient, and I know what their options are. And it has to be new every time, because I don't see them, it can be 4 or 5 months, 6 months before I see one.
Yeah, who's lucky?
Yes.
Could you comment on where's the thinking now with I've heard practitioners say in the literature that for poorly differentiated thyroid cancer, it kind of being in between papillary and anaplastic, and is that the way people think about it? That it's like that it has some of the characteristics of anaplastic, just poorly differentiated become anaplastic at some point?
Yeah, no, there's a lot of good questions in that. I believe it is a spectrum, and fortunately, most patients with differentiated cancer. So I personally believe that anaplastic probably goes through a differentiated phase. In some people, it might be that first cell, it just rapidly goes right on through to anaplastic, and all you see is anaplastic. Other people, it can be differentiated for a while and then flip over to poorly differentiated or anaplastic. Fortunately, not many people make that transition. So it's pretty rare. But I do believe that is a process that they go through, getting new mutations, that environment, talking to it can kind of trigger a more poorly differentiated. So it is a process. Fortunately, it's a rare process, and we can't predict ahead of time who's going to go and who won't.
Do patients who have anaplastic, do their treatments produce thyroid?
With anaplastic, no. One of the features of an undifferentiated or anaplastic, they don't make thyroglobulin. Even if you look at a lot of the genes in kind of, the enzyme genes and TSH receptor and all that stuff, anaplastic, they don't make. Some of them will make one called PAX8, but they don't usually make.
Because poorly differentiated papillary also doesn't make a lot of thyroid.
Most of them actually do. Most of them actually do, but we do see some patients with poorly differentiated where their blood level of thyroglobulin is not very high, and it's not a good marker. But fortunately, most with poorly differentiated make a lot of thyroglobulin. Yeah, they can be good markers. Yeah. And then, again, I'll come back to then the last slide, but again, this is the Maroon Bells. So this is where we go and hike and do all this stuff in Colorado. It's a lot of fun. And I want to thank all my colleagues, especially my oncology colleagues, Dr. Madeline Kane and Dr. Dan Bowles. They're the ones who really, as I always say, when we have a thyroid oncology clinic where we see the patients with advanced cancer together, and I'm a pseudo kind of oncologist there, I'm a thyroid oncologist, and those guys are my training wheels. So they help me along in these patients and their nurses, their oncology nurses, because advanced thyroid cancer and anaplastic, I don't think endocrinologists should just be taking care of it alone. It needs to be taken care of by teams. Teams of people who know about this. And so I'm very fortunate to have a great team at the University of Colorado. And also we're fortunate to get research support. And we've got some research support so we can do these kind of new trials and start working in these new areas. Because sometimes it's hard to apply to the NIH to get a grant to do something, especially if you're kind of being a little creative. Because a lot of times I'm on those study section panels and they'll look at them and say, I don't know, I don't think, there's a good chance this might not work, but it's worth trying. And these endowments really help with stuff like that. But I'll go back to this and answer any other questions you may have about anaplastic. Or welcome your comments. It's a tough cancer. It's that's one thing that fascinates me as a scientist, but frustrates me as a clinician, is that the same thyroid cell can be a 2-millimeter papillary that is probably never going to harm that patient, and that same cell can turn into an anaplastic, which is it's the worst cancer there is. I don't think there's one that's worse. I mean, some are, glioblastoma, bad pancreatic cancer. They're probably as bad, but I don't think there's anything worse than anaplastic as far as an aggressive tumor. Yeah.
Are you consulting with other doctors in other parts of the country too on these cases?
We usually don't call other doctors to say, what would you do? I mean, this is what we do at meetings, definitely. But what I would do is consult the doctor. Like, if I had a patient, Dr. Ann Graham's a medical oncologist at the NCI, I would probably call her about her study and say, here's this patient, do you think they potentially qualify for your study? Because I don't want to waste the patient's time if they wouldn't. So I will call people who run studies. And if we get into a spot where something doesn't make sense, I will call my colleagues. But usually we can do it at our institution. Yeah.
I think you mentioned Colorado was doing some preclinical work on anaplastic thyroid cancer. Go into that just a little bit, what kind of trends, what you're looking at?
Yeah. So what we're doing is we have tumor cell lines like a lot of other people do, and then we put them into mouse models. And we're looking at specific pathways that we think are important. One that you don't hear much about, but a colleague of mine, Rebecca Schweppe, works on, is one called the SARC-FAC pathway. And that's not a pathway that turns on cancer necessarily, but she has nicely shown it's a pathway that makes cancer worse. It makes it metastasize more. This pathway is more active in anaplastic than it is in differentiated. And so we're looking at trying to identify pathways that we can target in these more aggressive tumors and make them metastasize less, attack them. So we're not doing the one like what are the driver mutations, but we're like what's in there that's making them worse. And so that's just one example of what we're doing. Yeah.
What if you've had your thyroid out, and what about the follow-up with that if you are deemed then not, if you don't have it anymore?
So if you have anaplastic thyroid cancer and you have your thyroid out,
Right.
and then we say, by everything we can tell, you don't have it anymore. Kind of how do we deal with those folks?
Right.
First of all, we celebrate
Yes.
with the patient, and basically say, this is great, we can't find it. We have had patients, though, where it comes back. Usually in our young patients, and unfortunately I've had patients down to age 25 who've been diagnosed with anaplastic thyroid cancer at our institution. They're the ones who you might catch it early and you might be able to kind of get that initial response. We still follow a lot of those people very aggressively for at least a couple of years. So we're doing things like PET scans every 3 months in those patients because we don't have a good blood marker. And if they had it in their neck or their chest, usually we don't cure them with surgery if they have it in their chest. But if it was in their neck, we'll do good neck CTs and then we'll do PET scans. And we every time we see them and we can't find it, we celebrate, but we watch like a hawk because it can come roaring back within those first few years.
Okay, what about my mom, which just came in, and you took care of her, and it's been 7 years, and now she's cancer
Yeah, we still would recommend follow-up. And to me, at least 7 years out is great, and I would still, though, at least have a yearly visit. And then we can talk about imaging and things like that. We still should probably do some imaging. I think the chance of, if it's gone after 7 years, of coming roaring back is low but never zero with something like this. So we still need to monitor, but monitor less often. Like I said, we need to do it every 3 months at least, sometimes every 2 months in the first year or so. But then we get this far out and you haven't found it, we can do less frequent follow-up and cheer.
What would be?
Was it that mangosteen that did it?
Yes. And the water. You drink the non-acid alkaline water, pH balance.
You don't think it was our surgery and chemotherapy that did it? But mangosteen sure helped, right? We've talked about that.
With the spirit of the four in your gene, and Holy Spirit, not spirit,
The biggest spirit.
and mangosteen,
Mangosteen.
and for kingdom honor,
So we ought to add mangosteen to our rapid anaplastic response team, huh?
Amen, I agree.
Yes, sir.
A question about radiation. You're going to PET scan somebody for 2 to 3 years, every 2 or 3 months. Has anybody ever done any studies of the effect of all that radiation that person's getting?
Yeah, no, it's a good question. And there aren't studies necessarily in patients with anaplastic thyroid cancer of kind of what we're doing, but there are much bigger studies in general of if you do CAT scans on people, right? Because we do CAT scans for belly pain, chest pain, not even cancer. Your risk of getting another cancer is increased if you get lots of that radiation. That said, to me, finding and identifying and taking care of the anaplastic is much more important than a theoretical small risk of getting a cancer 10 years down the road. And so that's why we tend to use that up front. But in a patient who, let's say we've cured it, then I'd use lower dose CAT scans, I'd use them less often. But up front, I think the benefit of keeping an eye on that disease and figuring out what it's doing is much greater than the risk of a potential cancer that might not even happen 10 years down the road. So we think the benefits are much better than the risks there. In a little kid with cured papillary thyroid cancer, I don't do many CAT scans at all because I think the risk is worse than the benefit. Yes.
Have you had any treatments with hyperbaric oxygen for that kind of cancer and for the mouth and the radiation therapy? Have you
We actually have, it's interesting because we have both a hypobaric and a hyperbaric kind of chamber. The hypobaric is because of the high altitude stuff, and we do a lot of high altitude research here. But there is some hyperbaric work, and a lot of it more is with infections and tissue damage, less with cancer, and we ourselves have not done that. I'm not sure. There may be some people around the country who are, but I'm not as familiar with kind of hyperbaric oxygen. The theory, one of the theories is in cancer, of course, is that the tumor, and especially rapidly growing tumors like anaplastic, the middle of them are actually low oxygen. And low oxygen stimulates a lot of things that can tell the cancer to grow more. So one theory would be is to get more oxygen in there. I don't know if they've proven that putting somebody in hyperbaric, you can get much more oxygen, because part of the problem is there aren't a lot of blood vessels getting stuff there. So I don't know if there's been evidence that you can get more oxygen where it needs to go. There might be, I just don't know.
what happened was that I went to the middle school because my teeth were disintegrating very, very rapidly.
Mm-hmm.
Bone, and everything. And the one professor said we cannot treat her anymore until she has hyperbaric oxygen treatment.
Maybe to improve the tissues kind of around the teeth?
And I really felt a whole lot better for about a year after that was done.
Uh-huh.
And the hyperbaric really increased the oxygen. I noticed now I could go for another 31 days of it because I am low on oxygen and I can feel it. And I'm wondering if it should be looked into more as far as someone that had the extensive cancer
Uh-huh.
and the fast progressive
Yep.
cancer that I had. Would that have helped right after?
Yeah, and it's, you know, but I would say the simple answer is we don't know. And then the other simple answer is there are so many things we can potentially pursue, and there's only so much, you know, that we can put our energies into. And that in a way, if there are people who would be interested from kind of looking at that, I would say we just don't have the resources right now to do something like that. But it's very interesting, and that's like the person before who asked about the mTOR inhibitor, everolimus. If you find one patient who does well, you know, there should be hopefully people out there looking in to say, was it just a fluke and you happen to do well with it, or is there something more to it that we ought to study? You know, there's lots of things that we could potentially study, and I just don't know the answers.
I would think that they would put it in some kind of a clinical trial. with
Yep.
several people to find out who did well and who didn't do well.
And as we know, trials in patients with anaplastic, unfortunately, are very tough. Partly because there's just a few people here and there, and trying to pull them together, as we know, those studies can be quite tricky to do. So what we always try to do is to really focus and pick the studies. Maybe if some place wanted to do what's called a phase 2, where they just do a small group of patients to see if there is a signal. If there is, then we could consider doing a bigger, what's called multi-center trial.
It was interesting to me because it was a dentist that discovered that for me.
Well, yeah, I didn't know you could make the teeth better with hyperbaric oxygen. I always learn something when I come to these.
I think it was the bone structure.
Or just, yeah, probably the oxygen in that tissue as well. Huh. Anything else? Good. Thank you very much.